So I will introduce Dr. Pranay Sinha, we had the privilege of having here at University of Virginia as a medical student way back when. And then he went onward to Yale, where he did his residency. And then it's currently a leader in tuberculosis, but particularly within the field of how nutrition and tuberculosis intersect. And so we've appreciated his leadership in the world of infectious disease, but also in the world of malnutrition. So thank you so much for sharing with us. We're grateful to have you.
Thank you so much for that lovely introduction. And I hope before I proceed, it looks like my slides are making on there. And so this entire career of mine is built on a single lecture I attended in medical school, which is Dick Guerrant's lecture on worms. And he delighted in making us all nauseated with horrifying images that still haunt me. I still wake up screaming sometimes. But those images and his mentorship and his kindness have launched many, many journeys in the world of global health. And some of them are here in that room at UVA, but I'm one of them as well. And you will see how his work on malnutrition has influenced mine. And so when I start thinking about how to eliminate TB sustainably, which is what Dr. Guerrant charged me to do, it pushed me beyond my comfort zone a little bit, because it made me think about what we are doing with TB right now. So, Dr. Heisel's already done a wonderful job talking about TB and what a devastating illness it is. And I'll actually note that it has regained that horrifying crown of being the leading infectious killer worldwide. It killed 1.6 million people last year. Since I started talking, about 6 people have died of TB. And it's spread by airborne aerosols. We know this, and we've known this for years. And the burden of TB is not shared uniformly across the world. Now, we have a NTB strategy by the WHO that is going forward. It's got 3 pillars, which are integrated patient-centered care, bold policies, and supportive systems, which are supposed to get at social determinants, which have been brought up so many times. And there's also this focus on intensified research and innovation. Unfortunately, when you're in groups such as the WHO multi-stakeholder meetings and in any of these larger organizations that are targeting TB, you realize that they are first among equals. And I think the focus has been very much on healthcare and not on sort of the upstream factors. And perhaps that is why we are in a state where we are nowhere close to eliminating tuberculosis. This is where we have the milestones. As of 2025, we have to eliminate 50% of TB incidents worldwide. So we're supposed to get down to 5 million cases approximately. We are nowhere close. We've only reached about 8.7% of our target. And you can see in terms of mortality and catastrophic costs as well, we are nowhere close. And it made me wonder why that is. And it's important to ask this question now rather than persisting with policies that are not quite working, because there are many challenges for TB elimination that are coming ahead. We just saw how COVID-19 hobbled our TB elimination efforts. Armed conflicts, such as the one that Dr. Heisel invoked in Ukraine, are also disrupting TB care. Then Ukraine is particularly scary because of the drug-resistant TB and the rates of that over there. But even in Gaza, I'm worried that infectious diseases such as cholera and TB are probably going to kill more people than bombs. And lastly, climate change. And if you saw that map, the countries that are currently facing the highest burden of TB are the countries that will also face the greatest wrath of climate change. So these are things that we need to be considering as we go forward. So it is not a smooth sailing, and we should not assume that victory against TB is imminent. But the focus, again, remains on tools and technologies. This is the WHO's conception. They think by 2025, surely, you're going to have a new tool, a vaccine, new drugs to eliminate TB. I'm not sure. I mean, again, I'm not a Luddite. I do believe that there is value to sort of new tests and drugs for TB. Certainly, new drugs have revolutionized care for MDR TB, and we certainly need new tests, especially for children with TB, because it's incredibly hard to diagnose them. But surely that can't be all that is required to bend the curve. And by the way, we are not where we thought we were going to be at 2025. We're actually closer to that red line, intersecting that dashed line, than we are to where they thought we would be in 2025. So I thought back to what our approach has been. And our approach has been a public health approach. And in 1940, John A. Ryle wrote this book called Changing Disciplines, where he reflected on the difference between public health and social medicine. And public health, as was defined then, and we all know that public health and global health have colonial origins. It was really focused on the environment, housing, water quality, sanitation. Social medicine, on the other hand, focused on the person in that environment, thinking about the economic opportunities, the nutritional opportunities, the occupational opportunities, the psychological experience of being in those settings, and what that did to them and what that did to their health. And one of the best elaborations of social medicine actually was in Chile. And a lot of this came on the back of the Industrial Revolution, which really thrust people into these horrifying scenarios in urban Chile. And rates of TB were extremely high, some of the highest in the world at the time. And fortunately, at that time, there was also a very strong labor movement. And because of that, perhaps, there was this focus on social medicine. And so this was the prescription by Dr. Manuel Marin Rojas for eliminating TB from Chile, which was actually, if you look at it, a very human-centered approach. It was increasing wages, improving like the built environment in which people spent their time at home and at work, thinking about factors like alcohol use, venereal disease, and so on. And I think a lot of these would actually work today as well. We know from data that ventilation, like improving ventilation, can reduce TB transmission by about 50% in homes, in South African homes. We certainly know there are other risk factors as well. But this is the broad palette with which people were painting in the pre-antibiotic era. In the United States, this is the TB mortality curve. And what really strikes you is that a lot of the progress, but if we went back to 1860, the TB mortality rate in the United States was much higher than it is currently in South Africa or India. And there were some developments in 1871. There was the first sanatorium in the US in North Carolina. Around 1882, the TB bacilli were discovered by Robert Koch. And then right around 1900, you start seeing X-rays being used. They were not used dramatically. As of 900, the University of Pennsylvania had an X-ray they were barely using to look for fractures. The sanatorium movement was catching on, mostly among rich people who could afford to be away from their homes for 1 to 2 years, getting hotel level care. But then sanatoria did catch up a little bit, and they got up to about 673,000 beds at the peak of the sanatorium movement in 1925. Was that enough to isolate and get people away, get sort of infectious people away from the communities? I'm not sure that is the case. I think most Americans who needed sanatoria did not have access to them. And then 947, we get streptomycin. But what you'll see there is that most of this reduction in TB mortality in the United States occurred prior to the introduction of medicines or the BCG vaccine, which we know is helpful in children for a little bit, but is not a lifelong vaccine. And I think a lot of this has been ascribed to social progress, socioeconomic progress, which includes better living conditions, better nutrition, and so on. And it is important to note that these things are TB-sensitive interventions, not TB-specific interventions. And to me, that is, I think, where we need to go, because this explains, by improving the living conditions, by improving working conditions, by improving nutrition, you not only capacitate somebody to sort of not get TB, but you make them able to sort of live their life at a higher level. If using sort of the capabilities approach, which is posited by Martha Nussbaum and Amartya Sen, you see that you improve somebody's capability, and there are lots of positive externalities to these TB sensitive but not specific interventions. Unfortunately, a lot of that got lost. So when you got the biopsychosocial conception of TB, which is like this, where you're seeing how globalization and economic policies are feeding into generating poverty, and poverty is sort of leading to things like crowding, poor conditions, behavioral risk factors such as tobacco, alcohol, exposure to sort of HIV. Then you can see how all of that's feeding in. Unfortunately, the second we got medications for TB, it became a medical disease. We got locked into a very narrow public health approach for TB. And I may be being slightly unfair, but I think largely speaking, that is true. And this is some work we did in terms of defining what we are funding with our research. And what risk factors are we funding? And if you can see that, for example, malnutrition, which has got a population attributable fraction of 19%, got a minority of funding compared to HIV, for example. By the way, about half of that funding went to Dr. Heisel for his wonderful training grant in Tanzania. And so this just tells us that we are not looking holistically at this problem, and that is why we are failing to eliminate TB from the world. So, as I said, Dick Guerrant has been the most influential person in my life. And every day I find new ways in which he, some epiphany I think I've arrived at is something that he's documented in the 1970s. And so under him, I had spent some time thinking about the impact of early childhood malnutrition on cognitive impairment. And so when it came to confronting TB, I realized that malnutrition was a missing piece. And so I'm going to talk about that a little bit today. I'm not saying malnutrition is the whole picture, but it's an example of how we need to transcend the biomedical model to eliminate TB sustainably. And so it is the leading risk factor for TB globally. If you look at undernourishment on that population attributable fraction, so out of the 10.3 million cases in 2022, about 2.2 were attributable to undernutrition, which is really shocking. And there's some reasons to believe, by the way, that that is an underestimate, especially in countries like India. And this far outstrips HIV, alcohol use, smoking, diabetes. Not saying those are not important comorbidities, they are. And I think one way in which we would fail TB elimination is if we pit these against each other. That would be a failure of imagination, absolutely. And so the map I'm showing you over there, it is in red, you have the incidence of tuberculosis. In green, you have sort of prevalence of undernutrition. And you can see how well those maps kind of overlap with each other. And again, sort of really pointing out this very clear association. In the Global South, when I give talks, people kind of balk at me because they're like, well, you are Captain Obvious. We all know this already. They call it nutritionally acquired immunodeficiency syndrome, NAIDS. And it is the neglected cousin of HIV/AIDS. In fact, it is the leading secondary immunodeficiency worldwide, and it affects every aspect of the immune system, the adaptive, the innate. It is very extensive. And people knew this. People kind of recognized this, even though they may not have known what IL-6 or IL-13 was in sanatoria. But this was the cornerstone of the TB therapy, was good nutrition, and was associated with improved outcomes. There's this study from a US sanatorium showing a 10% mortality among patients getting cod liver oil and 70% in the control group. I'm not sure how great that study was, but overall, I think it was well recognized that this was a big component of it. Unfortunately, this again went out of style after the landmark Madras trial, which showed that you could treat patients with combination anti-tuberculosis medications in the outpatient setting. Unfortunately, it was kind of, we threw out the baby with the bathwater there a little bit, because the idea was, yeah, you didn't have to coop people up in hotel facilities for a year or two, because that did sort of delay their return to care and so on. And these TB medications that we had were miraculous for the time. But that didn't mean that nutrition didn't have a role to play at all. And we are finding that out today. We are kind of rediscovering what we already knew. So on the bottom left there, you've got sort of BMIs, body mass index, of individuals with TB in India. This is in 2013. That line represents 18.5, which is considered the sort of, it's a very arbitrary, somewhat cutoff for malnutrition. And what you see here is that before and after treatment, people remain severely malnourished. As Dr. Heisel has talked about HIV, it is inconceivable for us in the United States to treat somebody for TB and they have HIV and we don't address the HIV. That would be a failure of care for us. But but nutrition for some reason has escaped that scrutiny that HIV would get. And it is critical because we know that malnutrition, especially severe malnutrition at baseline, which is defined as BMI less than 16 kilograms per meter square, that is associated with a 4-fold increased risk in mortality. This was our study from India in last year, but it replicates work that has been done in Ukraine, in Ethiopia, in Malawi, in other parts of India. So we're not, I think there's fairly decent agreement here. And there are many reasons for this, because we know that there's a blunted response in these malnourished individuals. And obviously, and I'm sorry, my dogs are going wild back there because they're very excited for Dr. Guerrant. But in any way, I think there are multiple ways in which malnutrition impacts our sort of management of TB, because even if you complete treatment, there's a little bit of a mop-up required by your immune system to clear the bacilli. And if you're malnourished, that may not happen, and you have a high risk of relapsing. Additionally, there's increased risk of lung cavitation, and I'm not showing these data, but we've shown that malnutrition before the diagnosis of TB is associated with increased severity of disease. And then there is this question of variable drug exposure, adherence, toxicity. All of these things are affected by your nutritional status. And so we should really think about investments in nutrition as reinforcing investments we've already made in diagnosis and treatment. And unfortunately, we're not measuring anything right now. What gets measured gets managed. And so this is our conception of TB right now globally. This is what it could be if we started collecting actual data. And this is one of the lessons that Dr. Guerrant taught me that I think of every other day, basically, which is if you want to fix something, first measure it. And so we are beginning to sort of push the WHO to start reporting standardly the baseline nutritional status and weight gain for persons with TB, because we know that these are excellent prognosticators for how people do. Then there's the question of supplementation. There's been pretty lackluster research in this domain because these things are very nutritional interventions are expensive. And the ethics of it can also be questioned. In fact, I don't think there's equipoise at all, especially since several observational studies in Brazil, in Russia, in India have all pretty consistently shown that providing nutritional support improves treatment success. And I think a lot of that is by improving adherence to sort of the treatment and completion of treatment. And so this is the roadmap that we have generated, and I just recently showcased this at the Union Conference, which is when you start treatment, assess and report the nutritional status, provide nutritional counseling, which is already recommended by the WHO, and provide nutritional support. I think the highest bang for the buck for persons with TB is right in the beginning of treatment, because that's when the bacillary burden, the inflammation is the highest. And mouse studies have shown that provision of protein in protein deficient mice very rapidly improved their immune response and promoted survival. And at the end of intensive phase, this is another time to sort of reevaluate what's going on. And they're not gaining weight. This is a time to act, figure out, are they drug resistant? Are they not taking their medications? Is there a pharmacokinetic issue? Or is it just good old food insecurity? And there are, of course, things like pathogens. In fact, we are currently working on some figuring out what the prevalence of parasitic infections is in persons with TB, and it exceeds 40% in South India. So again, thinking about that is going to be critical. Lastly, at the end of treatment, if people haven't recovered nutritionally, it is our responsibility to connect them to sort of social services. Many times people don't know that they're entitled to rations and other social benefits, and we could connect them. And this is where I think creating a community of persons with TB, as Dr. Heisel did in Russia, using maybe mobile technologies, might be helpful in doing that. So this is the roadmap for navigating nutrition in persons with TB, but this is still thinking too downstream, right? People already have TB. So in that old metaphor of the broken bridge and the river and the drowning people, we are still just saving drowning people, which is urgent given the scale of the problem and given the mortality of TB. But we can't forget the larger picture, which is sort of what social medicine is about. And we know from prospective cohort studies that malnutrition is associated with increased risk of incident TB. This is data from Peter Cegelski at Emory, who demonstrated using the NHANES data set that in the United States, people with BMI less than 18.5 had a 12-fold higher risk of developing incident TB disease. Their data, we've not been able to show that high of a hazard ratio in India. We found a hazard ratio closer to 3. We're still trying to sort that out. And I know Peter Cegelski himself is sort of doing a very large systematic review now to sort of figure out what the actual risk is for people with BMI less than 18.5. In addition, there's also a real role for micronutrients. Megan Murray at Harvard has shown that there's a 10-fold increased risk of incident TB in people with vitamin A deficiency and about a 3-fold increased risk in those with vitamin E deficiency. So there has to be a focus on that as well. BMI, after all, is a very crude metric of malnutrition. And historically, there's so many examples where sort of a sudden nutritional shock led to worse outcomes. And so in German prisoner of war camps, we knew that British prisoners had a far lower rate of TB than Soviet prisoners. And that's because the Soviets were not getting Red Cross rations that had about 30 grams of animal protein and I think about 800 extra calories. And in Amsterdam, we saw a natural experiment play out when the Germans caused a blockade of the land and water routes. So all the food from the countryside could not make it into the city. And this is what precipitated the hunger winter, which Dr. Guerrant alluded to as well. And that led to this acute reduction in caloric intake down to about 500 calories for adults by February 1945. And there was increased mortality of all types, but TB in particular had a massive spike. And then you could see that spike go down after the war ended. And modeling has suggested that even small reductions in malnutrition could be massively impactful. And so this was modeling done by Olivia Oxlade and Megan Murray, and they showed that even a modest change in nutrition, following the Bangladesh National Action Program for Nutrition, could result in about 4.8 million cases fewer over 20 years of TB and prevent about 1.6 million TB deaths. And one thing that strikes me here is that there's not that much difference between modest change and near elimination of TB, which means we have to calibrate our policy responses, and even doing a little can do a lot, and we don't have to sort of pin ourselves to perfection. And so nobody had actually assessed the cost effectiveness of nutritional intervention. So my mentor, Bob Horsberg, pushed me to do that. And so I developed a very simple model of TB, which was people in India could be alive without TB. They could either remain healthy, die of other causes, develop TB. If they develop TB, they would either die or they'd be cured. And I model, India has a national ration system that serves, it's the largest welfare program in the world, serving hundreds of millions of people. It provides them with food grains, rice, lentils, sugars. And so I modeled providing a very rich intervention for people who are malnourished. The problem with a lot of these ration programs, people don't know about them. B, oftentimes they are mistargeted because they sort of target you based on your income level, but your income does not necessarily correlate with the level of deprivation. And so they're targeting errors. And so I said, let's get past that. Let's just say any Indian who's malnourished gets this intervention. And then I was able to sort of have them graduate beyond a BMI of 20. I said, I picked 20 because that gives you a bit of a buffer and also is low enough that you don't end up getting tipped into diabetes. And so if you reached a BMI of 20, you'd be considered graduated. That time you'd get whatever you would have gotten under the prevailing regime. And so with this, I sort of essentially used available epidemiological data to show that people with, when their BMI was less than 18.5, they'd have a high rate of development TB and dying of TB. Additionally, one thing I added here was if your BMI was less than 18.5, I assumed that there was a disability associated with being malnourished. And it is actually kind of shocking that this is not something that has been defined for adults at all by the global burden of disease. But I assume that, you know, if you're malnourished, BMI less than 18.5, your life was about 8% worse than it would have been otherwise. That was the disability rate I applied to being undernourished. So when I did that, I found that providing a national level, a population scale intervention for nutrition would actually be highly cost effective. It would have an incremental cost effectiveness ratio of about $470, which is a quarter of India's GDP per capita. And that is that would be considered highly cost effective. We'd have a very quick resolution of malnutrition. And then we'd have an 81% reduction in TB incidence and an 88% reduction in TB mortality. Now, when I saw those numbers initially, I thought I've definitely done something horribly wrong over here, because that's a massive reduction in TB incidence. Mortality seems unrealistic. But then I thought back to the data I showed you from the United States, and I said, well, it was possible in the US through social progress to see that massive reduction. So why would it not be true in India? And so this really, I mean, again, this is a model and all models are wrong, but some are helpful. And I was very heartened when I found that my model had been borne out somewhat by empirical evidence. So this was a large study that was just published in the Lancet this year and by our colleagues. And what they did was they took 2,800 persons with TB. They divide them in half in the intervention. All the persons with TB received nutritional support in this arm because we could not justify randomizing people with TB who are malnourished to a non-feeding arm. So all persons with TB received food, but the household contacts got randomized to receiving additional nutritional support or not receiving additional nutritional support. And essentially, those households where additional nutritional support was provided had about a 40% reduction in incident TB, which is massive. This is on a scale of TB preventive treatment, of a vaccine against TB. And so this was very, very exciting. And I've actually done a little bit of modeling around this. And again, the incremental cost effectiveness ratio of this intervention, even if I don't take the positive externalities of feeding people into account, even then, this remains a highly cost-effective intervention. So, and by the way, this is a lot less food than I had modeled in my own model. This is 750 kilocalories, and I had modeled about 2,600 kilocalories. So, what's really exciting about this is that it puts us in a different arena now. No, I think we are beyond the point. A lot of people ask me why sort of I bring up the ration study. I'm also conducting another study right now in Benin and Togo, where Benin provides programmatically nutrition support to all persons with TB. Togo does not. And people ask me why I do that, because isn't it obvious? Well, the problem is the funders of TB are all living in the global north, and the global south is where, you know, the impact of nutrition is apparent, but the funding priorities are not driven by our partners in the global south. And that's why these studies are important. And hopefully Rations has now put us in a place where we can start asking how questions instead of just if questions. The problem is even the people who did that study, they're still having a hard time getting politicians to care about nutritional interventions to prevent TB. And so when I went to Dr. Guerrant with this information, and I was talking about how disheartened I was, that it was difficult to get people to commit to nutritional support for TB, he told me, you need a bigger tent. And he's right, because, TB is a canary in a coal mine, right? TB has been described as the shadow of misery. And that's true. I think oftentimes is the final common pathway by which poverty kills people. The problem is we have a vertical program for TB, right? We are very focused on eliminating TB. We are counting, it's a notifiable disease. We are counting the numbers, we're counting the deaths from it and all of that, right? So if we just have a very TB specific intervention, that's like putting the canary on life support, and the miners who are around the canary, and, you know, if they continue with this life supported canary, oxygen supported canary, they are going to die. And so I think if we just focus on TB, and if we can eliminate TB by a TB vaccine, for example, I mean, that would be great, and definitely would prevent a lot of mortality, morbidity. But at the end of the day, we have not done all that we could for the people who were at risk of TB, because they will now die of community-acquired pneumonia and a whole host of other infections and non-infectious diseases. So I really think it's time. The reason TB, I think, has been mired in this biomedical approach has been that it's been run by the WHO. And the WHO has a limited edict. That's what my colleagues there have told me. They're not allowed to sort of think beyond the biomedical approach. They really are not encouraged to. They're told this is not your purview, stay in your lane. So we need, for multisectoral action, we need to broaden the tent and recognize that eliminating TB would affect multiple different sustainable development group goals, and getting all these different people, FAO, World Bank, USAID, UNICEF, UNHCR, all into line, and align their work through the multisectoral accountability framework would help. Otherwise, we're just like blind men who are touching different parts of the elephant, and thinking somebody's saying the elephant looks like a snake, the other one saying it looks like a tree trunk. We're all visualizing the problem through our own unique lens and not sort of getting a better resolution on the issue. And so I want to thank you. And I think one of the new technologies, not the only one, one of the new technologies that I think we need to leverage to bend the curve against TB is food. I hope I have been able to sufficiently argue for that. And I put Paul Farmer there because I think he would tell us that we are at that point where we have enough evidence where we need to stop studying excessively and start implementing. And I think that is where our focus needs to be, at least with nutrition and with other elements of other social determinants. And I love the saying, which is giving people medicine for TB and not giving them food is like washing your hands and then drying them in the dirt. So thank you so much for this opportunity to speak. And thank you, Dr. Guerrant, for giving me my career.